Misbehaving. Okay, so when we take an average person, okay, we are saying that every day the person will lose about 3.2 liters. 3.2 liters of water. Okay, and this 3.2, 1.7 of them is from what is called insensible heat losses. Okay, then 1.5 is from urine. Okay, sorry, I mean 1.3 is from urine, and then 200 mL is within the the feces. Okay, so when you add everything, you get 3.2 liters. Good. So this has an application. When you come to the ward, okay, and they are giving patients IV fluids, they give the patients 3 liters of IV fluids in a day. Okay, 3 liters of IV fluids in a day, and this for the clinical use. But you have to know also that if the patient is not taking in any fluid, okay, then in a day you must give the person 3 liters of fluid. Okay, good. So we give them about 3 liters of fluids in a day. So that's something I want you to note. Okay, now let's look at water regulation. Water regulation. So now you see some people may come either vomiting or dehydrated, or maybe even losing whole blood or something like that. Okay, so we want to see how this water is regulated. Now there are about 2 major ways in which water is regulated. So one is physiological. We all know that when you are thirsty, you go and drink water. Okay, so the physiological way of regulating water is by thirst. Okay, that is physiological. Like you just become conscious that you are thirsty and then you go and drink water. Okay, that is physiological. This has nothing to do with any hormones. Okay, so the hypothalamus has the thirst center. So when you are thirsty, you just go and then drink water. Good. So the first mechanism of water regulation is physiological. The second and the most important mechanism is the hormonal. So this one has to do with hormones. Okay, and the major hormone for water regulation is ADH, which is antidiuretic hormone, which is also called aldosterone vasopressin. Okay, that is the major hormone for water regulation. Now we know that the aldosterone vasopressin, okay, is produced in the hypothalamus, okay, but it is secreted via the posterior pituitary. Okay, so you have to get it clear that it's not produced in the posterior pituitary. Okay, as the slide is saying, okay, it's produced in the hypothalamus but secreted via the posterior pituitary. Okay, good. So there's the next concept that you should know is the concept of osmolarity and then osmolality. Okay, so that concept is about the number of electrolytes or ions in the system. Okay, the electrolytes or the ions in the system. So maybe sodium, chloride, calcium, potassium, those ones, including glucose, urea, and all those things. Okay, they give the blood its osmolarity. Okay, and that the osmolarity is about 300. Okay, everyone knows it's 300, but exactly it's 285. So to be precise, 285, but we approximate it to be 300. Okay, so if your osmolarity is greater than 300, we say you are hyperosmolar. Okay, and if it's below 270, you are hypo. Okay, hypo, I mean osmolar. Okay, and this osmolarity is that which controls ADH release. So it's the osmolarity of the blood which regulates ADH release. But that is not the only thing which regulates the release of ADH. And this is a past question. Okay, and it's in this slide. Okay, some things like pain also causes ADH to be released. And we know the function of ADH is that ADH goes all the way to the collecting ducts, okay, the collecting ducts of the nephron, and it increases its water permeability, okay, by producing channels called the aquaporins, okay. So what ADH is going to do is that it's going to the collecting ducts, okay, and then it's going to cause them to be highly permeable to only water, so that water will be reabsorbed. So ADH is released when the person's osmolarity is high. If your osmolarity is high, it means that the concentration of the ions are high. So you would like to dilute them and bring them back to the normal. So ADH is released when the osmolarity is high. Okay, that is the most important factor that causes ADH to be released. Okay, but there are some other factors too, like pain. Someone who is in pain, okay, or someone who is severely stressed, nausea, hypoxia, hypercapnia. So this part of the slide is very important. This part. So pain, severe stress, nausea, hypoxia, and hypercapnia. That's high level of carbon dioxide. Also stimulates vasopressin release by an unknown mechanism. Okay, they are saying that the mechanism is not known. Okay, let me see. Good. So that's one thing I want you guys to be aware of. Now, I also want you to be aware that the function of AVP, which is adenine vasopressin, which is also ADH. Okay, the same hormone. The name is vasopressin because it causes the vessels to undergo contraction. So it constricts blood vessels. Okay, it constricts blood vessels. So that's also another function of vasopressin. Okay, and I want you to remember that the function of vasopressin is not the same as the function of aldosterone. We will come to aldosterone, but aldosterone is for reabsorption of sodium and water. So for aldosterone, we are mostly thinking about absorption of sodium. When it comes to ADH, we are thinking about absorption of water. Good. There is also another potent stimulant of ADH, which is hemorrhage. Okay, and this for the clinical year students who have joined. Okay, when you read the badge, it says that hemorrhage or someone who is bleeding, hemorrhage is also a potent stimulant of ADH. So I've given you factors which causes ADH to be released. Okay, one, increased osmolarity. Two, hemorrhage, someone who is bleeding. Three, pain. Four, someone who is stressed. Five, nausea. Six, high carbon dioxide level. Seven, low oxygen level. So all these ones are important stimulus or stimuli of vasopressin. Okay, so I've talked about vasopressin. Now the second hormone is aldosterone, and I have already given you the principle that aldosterone mainly controls water regulation indirectly by sodium reabsorption. Okay, because we know that wherever sodium goes, water will follow. So if sodium is reabsorbed, then water indirectly is also reabsorbed. So what you should know is that the regulation of water by aldosterone is indirect. Okay, now let me add this important point because it will help us to understand the electrolytes. Anytime aldosterone works, okay, when sodium is reabsorbed, it is at the expense of either potassium or either potassium or hydrogen. Okay, so anytime you reabsorb sodium, you have to throw away potassium or hydrogen. So the two of them. So that means that if you have high levels of aldosterone, then you are going to reabsorb a lot of sodium, okay, and you are going to lose a lot of potassium and hydrogen ions. So this is how aldosterone works, okay? And aldosterone works on the distal convoluted tubules, okay? It works on the distal convoluted tubules. Good. So let's see. So that means that, okay, so there is a point here, okay, and we should know that aldosterone is released or is produced in the RAS system, renin-angiotensin aldosterone system, okay. Good. And I'm sure we all know the RAS system, so I'm not going to talk about it, okay. So someone with high aldosterone level, which is called aldosteronism, we know that this person is going to absorb a lot of sodium together with water, okay, and that's going to increase the person's blood pressure. Two, the person is going to lose potassium and then hydrogen ions. If you lose potassium, you get a condition called hypokalemia. And if you lose a lot of the H plus ion, you get a condition. If you lose a lot of the acid, then the base in your blood will increase, so you get alkalosis, okay. So, and that's the point being emphasized over here, okay, that's aldosteronism results in hypertension and hypokalemic alkalosis. That's a very important point. There's also a condition where the people or the patient has low levels of aldosterone, or the person cannot respond to aldosterone. In this case, the person's, I mean, the person will have, how do you call it? Low levels of sodium, okay, and that will bring the person's pressure down. But the person will have high levels of potassium and high levels of H plus ion. So the person will get what is called um, um, how do you call it? Hyperkalemic metabolic acidosis, okay? Good. But the person will have hypotension and hyponatremia. So if you understand this small concept, you'll be able to answer most of the questions with the water regulation, okay? Another important compound that's or chemical that affects water regulation is what is called the atrial natriuretic peptide, okay, the ANP. Now, as the name suggests, it is produced by the walls of mainly the right atrium, okay, or the walls of the atrium. Now, when the walls of the atrium expands, okay, then this hormone is produced by the walls of the atrium. So what's going to happen is that, and the walls of the atrium will only enlarge if you have a lot of water in your system. So that means that the function of this hormone, okay, is opposite to the function of ADH or vasopressin. So atrial natriuretic peptide works as an antagonizing hormone to the to ADH, okay, because atrial natriuretic peptide, okay, it is produced when you have a lot of water in your system. So its main aim is to let you urinate the excess water, okay. That's why the term nitriuretic is there, okay. That means that, I mean, if you hear the term diuretic, it means that you are urinating a lot, okay. But when you hear the term nitriuretic, it means that you are excreting or you are bringing out a lot of sodium, okay. Good. So this peptide is very important, okay. Once again, for the clinical yes name, that if someone has heart failure, you know that the person will have a lot of water in the person's system because the person's heart cannot pump. So the blood will accumulate in the heart. The heart will expand and it will release this ANP. Okay, so we use the ANP, the levels of ANP, to measure the degree of someone with heart failure. Okay. Okay, good. So I've explained what the ANP does. That when ANP is released, it increases the rate at which you excrete sodium as well as the rate at which you excrete water. So ANP is an antagonizing hormone for aldosterone and then how do you call it? Vasopressin. Okay. Now, as I said, vasopressin is called alginine vasopressin. Okay. And then the structure. Don't worry yourself, but you know that you notice that the structure of vasopressin and oxytocin, they are almost the same. Okay. There is this compound synthesized or synthetic ADH, which is DDAVP. I'm sure you guys met this drug in hematology. Okay. Okay, good. So I've talked about three major hormones which are used in water regulation. Okay. I've talked about vasopressin, I've talked about aldosterone, and I've talked about ANP. Okay. Now the last part of the slide, that is water disorders. Okay, so we are going to look at two main water disorders. Then we end this part. Okay, just 2 slides left. So we could have a condition called water depletion. So it's either the person has the condition called water depletion or water overload. Okay, so water depletion means that the person's total body water has decreased. Water overload means that the person's total body water has increased. Okay, so let's take the first one, water depletion. So usually, if someone failure to take in a lot of water or decrease water intake, okay, we will see this mainly on the ward. Okay, when people are admitted or people are unconscious, okay, people are in coma, they can't drink a lot of water. They can't drink water, so they go into this water depletion states. So that's one way. So inability to drink or unavailability of potable water. Okay, and then the second is when you are losing a lot of water. Okay, so we have diabetes, a condition called diabetes insipidus. So for diabetes insipidus, okay, what is happening is that you're not producing um, um, you are not producing vasopressin, you're not producing ADH. So it's either you are not producing ADH. If you are not producing ADH, we call that one central diabetes insipidus. Or if you are producing the ADH, but the ADH cannot work on the collecting ducts, we call that one nephrogenic diabetes insipidus. So for diabetes insipidus, there are two types. We have the central one and then the nephrogenic ones. Okay. Okay, good. So if someone has diabetes insipidus, the person will be urinating a lot of water. Okay. And that can also take the person into a state of depletion. Okay, so if this person comes to the hospital, you notice that the person is very, very thirsty. The person looks dehydrated. Okay, and then for someone whose water loss is as a result of reduced intake, okay, this person will produce high levels of vasopressin. Okay, but if the person's water depletion is caused by inability to produce vasopressin, then the person will have a state in which the person's vasopressin level is low. So if someone comes with dehydration, and maybe you measure the vasopressin levels, okay, I mean, we don't do that, but assuming you can measure the person's vasopressin level and the person's vasopressin levels is very high, then you know that, okay, the person's pituitary gland is functional. Okay, there are some questions. Let me answer some questions that some people have asked. Someone is saying that the ADH the ADH is not. Yeah, yeah, I've already explained that the ADH is made in the hypothalamus but stored in the posterior pituitary. Okay, someone is asking another question. That can I repeat the hypokalemic alkalosis? So you relax, okay? When we get to the electrolyte sites, I'll talk more about that one. Okay. Okay, good. So someone who is dehydrated, you will notice that now the person will have high osmolarity, because the person's blood will be concentrated because of the reduced water content. Okay. So how do we manage these patients? If the person is conscious, give the person water to drink. If the person is not conscious, you give the person IV fluid. Okay, especially 5% glucose. Now the reason why we give 5% glucose is that we give, let me say this for the clinical year students. Okay, if you are giving someone 5% glucose, what's going to happen is that the glucose can enter into the cells. Okay, and when glucose enter the cells, they can how do you call it, um they'll be metabolized, and then they will produce excess water. Okay, remember from metabolism of glucose, C6H12O6 will give us 6 carbon dioxide and 6 water. So if you are giving someone IV fluids with glucose inside, okay, that IV fluid will move into the intracellular compartments. Okay, so we use IV fluid with glucose, okay, to manage a dehydrated patient, someone who is chronically dehydrated and the person's intracellular volume compartment has shrunk. Okay, but we don't give IV glucose to someone who is losing blood and you want to replace the person's plasma volume. For that one, you just give the person normal saline. Okay, so for we call that one volume um, 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 replenishing the person's volume. Okay, like someone has come, the person is losing blood. Okay, you rather give the person normal saline so that the blood will stay within the plasma. Sorry, the fluid you are giving will stay within the plasma. But if someone is bleeding, okay, what we want to maintain is we want to maintain the person's blood pressure. So we want fluid to stay in the blood vessels. Okay, so for someone who is bleeding, if you give the person, you are resuscitating the person, and you give the person IV glucose, the glucose will not stay in the blood vessel, but rather it will go inside the cell. Okay. So that's what I'm saying, that we only give the glucose to someone who is dehydrated, someone who has lost intracellular fluid. Okay, because glucose will go into the intracellular compartments, because and when it goes into the intracellular compartments, it will be metabolized and it will give additional water. Okay, but for someone who you want the fluid to stay in the plasma compartment, okay, then that one you give the person normal saline. Okay, because normal saline will only stay within the extracellular compartments. Okay, good. Now the next condition, let me see, we have about 5 minutes to end the session. The next condition is what is called water overload. So for water overload, there are two causes. Either the person is intentionally drinking a lot of water, or someone with renal failure. If the person's kidney is shutting down, okay, the person cannot excrete the water, so the water will accumulate in the person. 3, for someone who is unconscious and you are giving the person IV fluid, and as I said, we give the person about 3 liters of IV fluid. For someone who is not losing water, we give the person about 3 liters of IV fluid a day. But if you are giving the IV fluids and you don't check and you exceed it, then you are going to cause water overload. Okay, this causes iatrogenic. We usually cause it. Okay, so this is excessive water intake. The last one, the second cause of water overload is when you have a condition called syndrome of inappropriate ADH secretion or ADH release. So this one, you are releasing a lot of ADH. And as I said, we know the function of ADH, reabsorption of water. So the person is reabsorbing a lot of water. Now, what can cause ADH to be released? There are a lot of factors which can cause excessive ADH to be released. Okay, so we've seen, I told you that someone who has an injury, someone who is losing blood, someone who has had surgery, okay, someone who is in severe pain, all these things increase ADH secretion. But there are some cancers as well. Okay, someone who has lung cancer, okay, some of these cancer cells can produce ADH. And then usually some infections, if you have lung infections and then brain infection, they can also stimulate ADH release. Okay, so with these ones, we get what is called the syndrome of inappropriate ADH release. So for such patients, what do we do? Reduce their water intake. Okay, and then you can even take them to dialysis so that the dialysis machine can remove the excess water. Okay, good. So we are done with water. Okay, the session will end, then we will come and look at the electrolytes. Okay, so please give me about 30 minutes more so that we can finish the electrolytes. Okay. Okay, good. Please, any questions before we end the session? Any questions? Please, any questions? Okay, no questions. So we will have, okay, yes, someone has a question. Okay, I don't think the person has a question. Okay, so we have 2 minutes for this session to end. Okay, so let's wait for the session to end, then we will start the electrolytes abnormalities. Okay, good. So someone is asking that what's the function of ADH? I said ADH is for pure water reabsorption. So that one is for water absorption alone, only water. Whereas aldosterone is for sodium absorption. Okay, but as we know, if sodium is absorbed, water will also follow. So the water regulation of aldosterone is indirect. Okay, it's indirect. And let me also emphasize that I said that when you have when aldosterone is working, okay, aldosterone of course reabsorption of sodium and then excretion of potassium and then hydrogen, potassium and hydrogen. So that means that if you have high aldosterone levels, then you are going to absorb more sodium. Okay, so that will lead to hypernatremia. You are going to absorb high sodium and you are going to excrete potassium and then hydrogen. So if you're excreting potassium, that means that you are losing a lot of potassium. So you have hypokalemia. And if you are losing a lot of acid, then you have alkalosis. So usually, remember that usually the hyperkalemia, okay, sorry, the hypokalemia goes with alkalosis. Remember that hypokalemia goes with alkalosis. Okay, so we will continue in the next session.